all-cause mortality with non-AVK antagonist oral anticoagulation, so-called NACO, versus warfarin in atrial fibrillation. It's a nationwide study.
Okay, thank you for the opportunity to present this study. These are my declarations of interest. Atrial fibrillation affects approximately 33 million people worldwide. And also, atrial fibrillation increases the risk of stroke. But if we treat patients with oral anticoagulation, we are able to reduce the risk of stroke. And in Denmark, we have had 4 treatment options until 2016, and that is warfarin, dabigatran, rivaroxaban, and apixaban. But all anticoagulation treatment is a double-edged sword. It lowers the risk of stroke, but increases the risk of bleeding. And in particular, we fear the risk of intracranial bleeding. With several treatment options, comparative data is needed to help answering the clinical question, which all anticoagulants should we choose? So the purpose of this study was to compare the associated risk of ischemic stroke and intracranial bleeding with NOACs compared with warfarin among patients with atrial fibrillation. And this was an observational study based on the Danish nationwide registries. And now the results. We included 43,000 patients with atrial fibrillation who were new users of all anticoagulation treatment. And warfarin was initiated in 42%, dabigatran in 29%, rivaroxaban in 13%, and apixaban in 16%. And first I'll present the result for ischemic stroke and then for intracranial bleeding. This figure shows the unadjusted absolute risk of suffering from a stroke. And on the x-axis, we have time since the 4 different treatment option was initiated. And on the y-axis, it is the unadjusted absolute risk. And we saw that at the time of 1 year after treatment was initiated, the absolute risk of suffering from a stroke ranged from 2% to 3%. But we also calculated the standardized absolute risk, and in this model, we take other diseases into account. And we saw that at the time of 1 year after treatment was initiated, the absolute risk of stroke was 2.0%. Dabigatran, it was 2.1%. Rivaroxaban, 2.1%. And apixaban, 2.5%. And none of the NOACs had a higher or lower risk of stroke compared to warfarin. So to illustrate this, if we had 1,000 patients who had atrial fibrillation and initiated a NOAC or warfarin, well, 20 to 25 patients would suffer from a stroke at the time of 1 year after treatment was initiated. And now the result for intracranial bleeding. And we saw that the unadjusted absolute risk of suffering from intracranial bleeding was lowest for patients treated with dabigatran. Also this time, we calculated the standardized absolute risk. And we found that at the time of 1 year after treatment was initiated, the absolute risk of intracranial bleeding was 0.6% for warfarin-treated patients. For dabigatran, it was 0.3%, and this was significantly lower compared to warfarin. For rivaroxaban, it was 0.5%, and apixaban, 0.4%, and this time also significantly lower compared to warfarin. And again, to illustrate this, if we had 1,000 patients treated with warfarin, well, after 1 year, 6 patients would suffer from an intracranial bleeding. If treated with apixaban, this would be 4 patients, and 3 patients if dabigatran was used. So, in conclusion, among patients with atrial fibrillation who were new users of oral anticoagulation, we found that the absolute risk of stroke at the time of 1 year after treatment was initiated ranged from 2.0% to 2.5%. And treatment with dabigatran, rivaroxaban, and apixaban was not associated with a lower or higher absolute risk of stroke compared to warfarin. The absolute risk of intracranial bleeding at the time of 1 year after treatment was initiated was 0.3% for dabigatran, and this was the lowest absolute risk. And it was only treatment with dabigatran and apixaban that was associated with a significantly lower risk of intracranial bleeding compared to warfarin. Thank you.